All right. Good morning, everyone. Welcome. It's 9:15. A great start to the last morning of the conference. And we are thrilled to be back to talk about more with the QTc and EKG. And what we wanted to do for this workshop today is to really make the whole thing about complex cases. These are all going to be new cases that you haven't seen before. And we're going to make a little bit of a competition out of it so you can kind of test your own knowledge about where you are with your understanding of QTc prolongation, medications, and then how to think about a risk assessment. And with the cases that we have today, we really wanted to make an effort to throw in some elements thinking about social determinants, ethnicity, sex, environment, to kind of go along with the meeting's theme, and also a variety of age ranges are represented by the cases today. So I am joined by Dr. Scott Beach and Chris Solano, and we've been doing this together for a while now, and it's pretty fun. So I'm Margot Funk. I'm the director of cardiovascular psychiatry at Brigham and Women's Hospital. I'm also the vice chair for education and the residency program director there. Dr. Beach is associate professor of psychiatry at Harvard Medical School and an attending psychiatrist on the CL and acute psychiatry services at MGH and former program director of the McLean MGH residency program. And then Dr. Chris Solano is associate director of the cardiac psychiatry research program at MGH and associate professor at Harvard Medical School. So today we're going to test your knowledge about all things related to the QTc and CL psychiatry. Hopefully can fill in some knowledge gaps, and also want to present you with some of the latest updates, and most importantly, to have fun. So first item of business is to log on to our competition poll. So if you will join in, you can either go directly to your web browser on your phone, and what you're going to be looking for, the login is right up here. So pollev.com/MargotFunk977. And if you happen to have Poll Everywhere as an app, you can log on to that app using this logon as well. We'll give everybody a moment to do that. And as you start to get in, can you just give me a show of hands so I know we're getting in? Chris is in. Good. Great. Anybody having trouble? Okay. Excellent. All right. So let's get started. So first, Dr. Solano is going to talk about the ECG and QTc with some great cases associated with that. So Dr. Solano.
Thanks very much, Margot. And so I have the pleasure of talking about a basic overview of the QTc. What we're going to end up talking about is a little bit about what the QT interval represents, how we go about measuring it, and some certain clinical situations where we actually have to tweak the way that we actually measure the QTc. So I have no disclosures. And first, I'm going to start a little bit with a case. So Mr. F is a 52-year-old man with a history of atrial fibrillation, hypertension, chronic pain, and opioid use disorder in remission on methadone, who was referred to you from his primary care physician due to worsening anxiety. So this could be a pretty typical case. The person had kind of a car accident in the past, developed low back pain, started taking opiates, ended up developing opioid use disorder, is now in remission on agonist therapy. So you end up seeing this patient, you evaluate him, and you kind of decide that though he was never been treated for an anxiety disorder, he actually does have a history of long-standing anxiety, and you think his symptoms are probably pretty consistent with generalized anxiety disorder. His medical history includes atrial fibrillation, which is rate controlled. He has hypertension, and then he has low back pain. In terms of his family history, it is notable for anxiety disorders on the maternal side of his family. And his mother takes escitalopram and finds it to be quite helpful. And so he's actually kind of interested in escitalopram as an option, given that he has this family history of a positive response to that, and thinks it could be possibly good. In terms of his medications, so he's on methadone 120 milligrams a day. He also takes trazodone for insomnia at bedtime. He takes gabapentin for his low back pain. And then for his atrial fibrillation, takes metoprolol. He also has some amlodipine and hydrochlorothiazide there. You look at his labs, he has a potassium level of 4.2 and then a magnesium of 2.3. And his most recent EKG was 9 months ago. At that point, the heart rate was 93 and the machine read was 472 milliseconds. You don't actually have the EKG itself. You just have kind of this little report that has these numbers on it. And so the first question is, kind of based on the available information, what is our next step in terms of treatment? Goodness. So the options are, I'll read the options for you. Basically, the option A is kind of start a medication for the management of generalized anxiety disorder. Oh, it's good. Okay. Look at your phones for the options, and then feel free to pick. But the options are start a medication, obtain an EKG, or it depends. Is it working for folks? Some folks no, most folks yes. Okay, so we've got obtain an EKG is the answer. I think this is actually a tough one. I would actually probably say it kind of depends in part on what medication you want to start. If you want to start escitalopram, then I'd probably say checking an EKG certainly makes sense. If you wanted to start another SSRI, there's actually really not much evidence that most of the other SSRIs cause significant QT prolongation. So I would say if you don't have it, or if you don't have it available, that wouldn't necessarily stop me from starting to treat this patient. If we think about this patient in particular, what risk factors would you think this patient has for QT prolongation? And again, there should be a list of potential risk factors there. And I'm sorry, this may mess up with the points, but for some of these, I don't think that there's necessarily just one correct answer. So don't get too stressed out. It's kind of a didactic more experience here. Let's take a look here. All of the above is kind of the one that gets the most. So I would actually think about this patient. So I think he was 54. I wouldn't probably say all of the above. Certainly, when we think about risk factors for QT prolongation, older age is a risk factor. Female sex is a risk factor, particularly from kind of the age of puberty to the age of menopause, which we think is maybe due to kind of estrogen effects. I would say in terms of this patient, his electrolytes were actually okay. His potassium was kind of 4.2 and his magnesium was, I think, 2.3. I would say if we had any arguments, we could either say structural cardiovascular disease because he does have atrial fibrillation, but I think the biggest one is probably medications. He has, we know he's on methadone. We know methadone is a pretty potent QT prolonging agent. And so that would be the thing that I would be most concerned about with him. My gosh, there's a leaderboard. Nice job. Finola. If an EKG were not available, which medication would you end up choosing? And so the options I gave here were escitalopram, sertraline, nortriptyline, or venlafaxine. So this is assuming you don't have the ability to get an EKG right now, but that his anxiety is pretty severe and you want to try to start something on the sooner side. Yeah, so his EKG was normal. I think it's interesting because if we believe what was said and we know about the different formulas that we use to correct the EKG, that his initial EKG from a few months ago probably isn't overestimated what his QT interval is. So I could see where somebody might say escitalopram, but I would probably go with sertraline. We certainly know that SSRIs are first-line pharmacotherapy for generalized anxiety disorder. And we know that sertraline is probably the medication that's been best studied in cardiac populations, and it really causes minimal QT prolongation. So if we didn't have an EKG, I would probably go with sertraline. So with that, let's kind of take a step back and review a little bit of what the QT interval is, how we go about calculating it, and then also think about the kinds of things that we really want to think about for measuring in certain clinical situations. So the QT interval, you can see at the bottom of the screen, it really reflects two different physiologic processes. So the QRS complex reflects ventricular depolarization, while the ST segment and T wave, which is also known as the JT interval, reflects ventricular repolarization. And if we kind of look at the same thing on a heart, when you think about the cardiac action potential, it starts in the SA node in the right atrium. It kind of travels through these internodal pathways to the AV node. And when that's going on and atrial depolarization is happening, you end up seeing the P wave on the action potential. Once the action potential moves through the ventricles, it goes through the bundles, it causes ventricular depolarization, and atrial repolarization is happening at the same time. And you see that as the QRS complex. And then finally, you have this ventricular repolarization, which is seen by the JT interval, which is the ST segment and the T wave on the EKG. And when we think about what's going on, there are really three different ions that are particularly involved in the cardiac action potential. So in the cardiac myocyte, it's usually kept at this negative state at its kind of resting state. And when depolarization happens, the first thing that happens is there's this rapid influx of sodium ions, which causes depolarization. Then there's some efflux of potassium ions and an influx of calcium ions that leads to this temporary period where there's kind of a depolarization in a relatively steady state. Eventually, potassium overtakes calcium, and this leads to the negative state again happening. And when we think about drug-induced torsade de pointes or QT prolongation, this usually happens because of that potassium channel. So we think about the medications, they end up going and they block some of these potassium channels. So when repolarization is happening, it ends up happening more slowly than you would expect. This is kind of manifested on the EKG as a widening and distortion of the T wave and QT prolongation when you're actually measuring the QT interval. And if you actually look at what this looks like on the EKG, you can see in the kind of gray, this is what a normal T wave would look like. But if you have one of these medications, you might get this kind of lengthening and kind of blunting of the T wave, which represents kind of prolonged repolarization. So when we go and actually measure the EKG, there's a few things to kind of keep in mind. So first, every little box on that EKG is 40 milliseconds, and one of those big boxes is 200. And there's a number of different intervals that we usually think of that are kind of important. The ones that we'll talk about today are the QT interval, the RR interval, and then we'll also mention the QRS complex because that is kind of what plays a role in the QTc as well. And then when you're actually putting the information into one of these formulas, you can either use the RR interval or you can use the heart rate. So there's a few ways to kind of remember or tricks to think about how to measure heart rate. So the first thing is that when you get one of those sheets with the EKG, it's 10 seconds long. So if you just count up the number of beats and you multiply by 6, you end up getting the number of beats per minute. So that's useful when you're using the Hodges formula. Or you can kind of just memorize this as well to give yourself a nice estimate of what the QTc is or what the heart rate is. And then there's the process of actually measuring the QTc. So I usually think of this in 4 steps. First, you need to pick an appropriate lead. We would usually say picking lead 2, V2 or V3 is probably the best way. The things that I'm really looking for when I'm looking at a lead is trying to see where I can see the end of the T wave most clearly, because that usually is the hardest part in terms of kind of calculating the QTc. Also, these leads tend to be kind of longer in terms of QTc. You then measure the QT interval. You then measure the heart rate or the RR interval, and then you put it into a formula to calculate the QTc. So if we took a look at an example here, when you're looking at the start of the Q wave, you kind of would draw a line where that is. You then draw a line at the end of the T wave, and then you count up this number of small boxes and multiply by 40, which in this case is 370 milliseconds. You're not done there because you do need to correct for heart rate. And so what you end up doing is you start looking at the preceding RR interval. So if we kind of take a step back and we zoom out, we can see that we have our QTc from this particular action potential. But then we're going to look at the peak of the last R wave to the peak of the current R wave. We're again going to measure the number of small boxes and multiply by 40 milliseconds, which in this case is 690 milliseconds, which corresponds to a heart rate of 87 beats per minute. And then finally, we put it into one of these formulas. If you're interested in thinking about some of these formulas and which one's the best and which one's the worst, you can certainly look at some of our talks from last year where we went into a little more detail. But the biggest takeaway is the Bazette formula is what is usually on the EKG machine. That's probably the least good one in terms of taking a look at the QTc. It tends to really overestimate the QTc at higher heart rates and underestimate at lower heart rates. And so we usually recommend using one of these linear correction formulas like the Framingham or the Hodges formula. I like the Hodges just because you don't really have to measure the RR interval. You can just use the heart rate. And the thing that I wanted to illustrate is that when you use the numbers that we just kind of calculated, you do get differences in terms of what the QTc is using these different formulas, where the Bazette formula is pretty much always a little bit higher if the heart rate's above 60 than some of the others. So let's say in our current case, we actually get the EKG. Here you can see what the 12-lead EKG looks like. The things that you would notice is that the person is in atrial fibrillation. You can't really see any P waves there. You see a lot of kind of like fluctuations on the baseline. And then you can also see that it's irregularly irregular. So when you look at the different RR intervals, you can see that they're not exactly the same. So when we actually go and try to look at atrial fibrillation, how do you deal with that when you have different RR intervals and variations over the course of the EKG? So the way we usually do this is actually trying to either average the smallest and the longest complex, or you average as many complexes as you can. I would say for me, I'll usually try to get kind of a nice little area where I can see the end of the T waves, and then I'll try to pick one of the longer RR intervals and one of the shorter ones. So if we kind of look at one of these little segments, you can see that there is this variability in RR intervals. And when there is variability in the RR intervals, we also will see variations in the QT interval. So if we went and calculated one of these QT intervals, like this one over here, which has a short RR interval preceding it, you can see that the QTc is 360 milliseconds. When we do one that has a longer RR interval preceding it, you can see that the QTc is actually a little bit longer. It's like 400 milliseconds. And then if we calculate our RR intervals, we end up getting 540 and 640 milliseconds. And then we just average them. So we calculate the QTc. I have Hodges formula here for both of these. But if you start plugging in the numbers, you can see that the QTc for that first one was 449 milliseconds. And the second one was 360, which is actually quite different. So if you really just picked one, you could kind of be off substantially in terms of what your QT interval is. So if we then average those two things, we end up with a QTc of 405 milliseconds. So if we think about this particular person, QT is not really prolonged at all, which is great. So now with this information, you got your EKG. Which medication would you now think about choosing? And I'll give you the same options as before: sertraline, nortriptyline, venlafaxine, and escitalopram. Okay, nice. Interestingly enough, everybody picked escitalopram, but sertraline got the little check mark. I don't know why that is, but I would say I would still go with I think escitalopram is a fine option in this case. I would say if he responded and if his QTc is normal and all other things being equal, escitalopram is certainly it is perfectly fine to use. I think sertraline is also fine to use, but either way is good. If you were using escitalopram, how frequently would you monitor the EKG to measure the QTc? So options are never, every month, when risk factors change, every 6 months, or annually. Good, great. I would say when risk factors change would be my choice here. I think that typically when somebody's on a medication that's a higher risk medication, what you really want to do is remeasure the EKG after dose increases once the person is at steady state on the higher dose, or if there is kind of a change in other kinds of risk factors, you would want to check it again, because as we all know, like psychiatric medications are only one of many risk factors for QT prolongation. So in this particular case, Mr. F started escitalopram 10 milligrams a day. This was titrated up over time to about 30 milligrams a day. His generalized anxiety disorder symptoms improved, and his QT interval remained stable throughout the rest of treatment. So that was great. He had a good outcome. So the next case talks about something a little bit different. So rather than atrial fibrillation, we're going to see some other kinds of issues come up. So Ms. D is a 74-year-old woman with a history of heart failure with preserved ejection fraction. She also has a history of an arrhythmia and has a pacemaker. She has hypertension and she has major depressive disorder, and she ends up getting admitted to the hospital for altered mental status. They do a workup, they discover that she has a urinary tract infection, and she ends up getting started on levofloxacin. Unfortunately, her course is complicated by hypotension, confusion, and agitation, as well as QT prolongation, and so you end up getting consulted for this. So this sounds pretty typical. In terms of her medications, she is on fluoxetine, 20 milligrams a day. She's on trazodone, 50 milligrams at bedtime. She's on torsemide for her heart failure. She's also on lisinopril, and she's on the levofloxacin for her UTI. In terms of her laboratory studies, the things that are most notable for this are that she has an elevated white blood cell count. She's mildly anemic. She has a potassium level that's a little bit low, potentially related to her diuretic. And her magnesium's a little bit low as well. And her vital signs are notable for being febrile. Her heart rate's actually kind of low and is ventricularly paced. And her blood pressure is a little bit low as well. So in contrast to the last person, what kinds of risk factors does this patient have for QT prolongation? And I'll give you the same kinds of choices that we talked about with case number 1. Yeah, so in this case, I would say all of the above is probably true. This is an older woman. She has structural cardiovascular disease. She has heart failure. We know that she has some electrolyte disturbances, so she has hypokalemia and hypomagnesemia. And she's also on a number of medications that potentially could prolong her QT interval, including the levofloxacin that she was just prescribed for her UTI. So let's take a look at this EKG. So this is what her EKG looked like. I put the readout on the right in terms of what the different intervals are. And the things that I think should be kind of very visible immediately are that there are these kind of pacing spikes. So she is being ventricularly paced. And her QTc is quite long on the readout. So based on this information, what do you think your next step would be? So do you want to just calculate the QTc? Or is there something else you have to do in this particular situation? I feel like this is kind of a leading question. We're all good test takers, so hopefully this works out. Okay, good. So we probably need to at least think about adjusting for a wide QRS complex. And so the reason why we end up needing to adjust for this is because of the ventricular pacing. So when somebody has a ventricular pacemaker, they end up getting changes to their QRS complex that leads to prolongation of it. And when there's prolongation of the QRS complex, that is a prolongation of the QT interval, but it actually reflects prolonged depolarization rather than prolonged repolarization. And when we think about the reasons why people end up having these kinds of ventricular arrhythmias, it's usually because of prolonged repolarization. Because when repolarization is prolonged, the cardiac myocardium becomes kind of susceptible to these extra beats that can trigger these arrhythmias. So when somebody has a ventricular pacemaker, their QTc looks long, but it's not really as big of a risk as you would think. And so there are really several ways to approach this. And Margot actually published a paper a couple of years ago that go through some of these options. There are more options, like way too many options. I don't know why people spend so much time thinking about exactly the best way to correct, but it's like a whole thing. You need to do two different real steps here. The first is that you actually need to obtain the usual EKG measurements that you would normally obtain, except in addition to what you normally would obtain, you also measure the QRS complex. And then you need to ask yourself an important question. Is the QRS complex prolonged? So a normal QRS interval is usually 80 to 100 milliseconds. And so if you use 110 as kind of a cutoff, you'll then decide whether or not you can just calculate the QTc normally, or if you actually need to adjust for the wide QRS complex. Once you do that, if you do want to adjust for the wide QRS complex, there are a few different options. Option one is to do something called the Bogosian method. And all three of these really try to basically account for that wide QRS complex. So in this case, you calculate a modified QT interval by subtracting out half of the QRS complex. So basically you measure the QRS, you say, okay, let's pretend that half of this is normal. And then you just kind of calculate your modified QT. And then you put that into one of the linear correction formulas like the Hodges formula. The nice thing about this is that you still have the regular kind of QTc upper limits of normal. So you still would really be concerned if the QTc is above 500. Now, option two is to calculate the JT interval. So the JT interval starts at the end of the QRS complex and goes to the end of the T wave. So this takes the QRS complex out of the equation altogether. And you can either measure that yourself, just looking at the EKG, or you can subtract the QRS complex from the QT interval, and then you use the Hodges formula or another linear correction formula to calculate a corrected JT interval. This is nice in that you actually are just kind of getting rid of the problem, which is good. The downside is that you do need to use these kind of different upper limits of normal. So you can't just be like, oh, 500 is the prolongation I'm worried about. And then finally, both of these used kind of two different steps. You needed to kind of do something, and then you needed to put it into a formula. Well, the Rada-Harju method actually allows you to really just use one formula. So it's a one-step process. The downside is that it's quite a complicated formula. So if you're like, it's not like super easy to kind of think about when you're at the bedside. So in this case, what we would do is we would obtain some EKG measurements. So if we kind of looked here, this would be what our QT interval looks like. So we started right at the beginning of depolarization and the end of the T wave. We count up the boxes and multiply. So in this case, 560 milliseconds. We then calculate the preceding RR interval, which we end up getting 970 milliseconds or 62 beats per minute. And then we do the extra step of calculating the QRS complex, which in this case is 180 milliseconds. And so then you ask yourself the question, is the QRS complex greater than 110? In this case, yes, it is. So we need to use one of those other formulas. So you could use any of these three options. I did want to show you all three. We're not going to like go through them very much in detail, but there are a little bit of differences between them. So if you use the Bogosian method and you calculate your modified QT interval, it's 470. And since it's really close to 60, there's not much correction you need to do. So you get 473.5. If you look at the JT interval, we can measure it here like we just talked about, or you can actually calculate it yourself. If you look and you put in the numbers, you end up getting a JT interval. I'm sorry, that's a mistake. That should be JTC at the bottom, which is 383.5, which is a little bit over what we would typically kind of worry about. And then if we use the Rada-Harju method and we put everything, all of these numbers in here, we end up getting 492 milliseconds. So our option 1 and option 3 are still a little bit below 500. Option 2 was a little bit above like the upper limits of normal, but probably similar. They're all like a little bit elevated, not like super crazy, like terribly elevated. All right, so pick up your phones. Which medication would you consider using for the management of agitation in this patient? So we've got haloperidol intravenous, intravenous chlorpromazine, intravenous dexmedetomidine, intramuscular olanzapine, or intravenous valproic acid. We're assuming that this person can't take anything by mouth because she's agitated and confused. Yeah, this is a good question. I don't know. This was one of those ones where I was not quite sure. I think that there are arguments for a lot of these, okay? I think that QTc is one particular aspect of this, but we also know that she's hypotensive, so that would go into my decision-making. We also know that she's kind of borderline bradycardic, although she is on a pacemaker, so she has a pacemaker, so hopefully she wouldn't get super bradycardic. I think you could go with any number of these. I think haloperidol is certainly an option. The things that I like about haloperidol are that it does cause a little bit of QT prolongation, but most of the research shows that it causes about similar prolongation to other antipsychotics. And so I wouldn't choose haloperidol. I wouldn't not choose haloperidol because of the QT prolongation compared to olanzapine or chlorpromazine. I do like it doesn't cause the blood pressure changes. It's not going to affect the heart rate really. So that's kind of nice. And the QTc wasn't over 500. So I feel like there could be an argument for that. Chlorpromazine, I probably wouldn't do, given the hypotension. And it can cause QT prolongation as well, so that probably wouldn't be my option. Dexmedetomidine has the benefit of not causing QT prolongation particularly. It can cause bradycardia, but she does have a pacemaker, so she's protected from that. But it can also cause hypotension, so I could see some reluctance to using dexmedetomidine as well. Olanzapine can cause QT prolongation, similar to haloperidol. I'm not a big fan. It can cause hypotension. I'm not a big fan that it's intramuscular because that's kind of annoying and painful and may kind of make somebody more irritated and agitated. So I actually probably would go with valproic acid or haloperidol. Either of those two would probably be my choice. If I was more worried about the QT prolongation, I'd go with the valproic acid. And if I wasn't as concerned, I might stick with the haloperidol. Now, in this particular case, how frequently would you then monitor the QTc if they were on, let's say, haloperidol or one of the antipsychotics? And the options are never, once a week, when risk factors change, daily or continuously. All right, this is good. So I feel like when risk factors change or daily are probably good answers. I would say that if we do think that this patient is on multiple medications that can cause QT prolongation, they have electrolyte abnormalities, they're going to be getting a bunch of different changes in treatments, you could make the argument that risk factors are always changing, and so we probably should be measuring this kind of on a daily basis. I wouldn't be doing it continuously. I would use continuous monitoring if somebody were, had a QTc of 600 or something like that, where we knew that it was prolonged and we were really worried about kind of ventricular arrhythmias. In this kind of case, I think that's probably more than you need, but I think daily or when risk factors change would kind of make sense. I think it's probably easier just to do it daily, but that probably is when risk factors are changing. So in terms of follow-up for this patient, we talked to the medicine team. They actually were able to use a different antibiotic that was less likely to cause QT prolongation. She had her electrolytes repleted. Her follow-up EKG kind of the next day demonstrated some improvement in the QTc, now 460 milliseconds when we adjust for the prolonged QRS complex. And so she ultimately got treated and then improved and was discharged home. So again, kind of like good outcome. I mean, 2 good outcomes. You guys are awesome. This is good. Saving lives. And with that, I will kind of stop and I'll let Scott come up. He's going to do a review of the QTc and psychiatric medications, hopefully giving you guys an up-to-date information about medications. So thank you.
Thanks, Chris. A big thank you to Margot for getting us all organized again and helping us with the cases. Thank you all for coming to this on a Saturday morning. And I'll say I am doing terribly in the competition. So I hope that is not because I don't know anything. So I think an important take-home message here is that a lot of these cases are subjective and these are clinical decisions, and oftentimes there's no right answer. I don't have anything to disclose with regards to this talk. So I'm going to jump into a case as well. I have a pretty long case, and this is actually based on a real life case that we had over the summer. So 64-year-old male, history of severe alcohol use disorder and recurrent major depressive disorder, who has an extensive cardiac history. Status post 4-vessel CABG. He has ischemic cardiomyopathy with an ejection fraction of 35%. He underwent cardiac resynchronization therapy with a pacemaker and an ICD, and he has longstanding persistent AFib that is now paroxysmal. He comes in following an ICD shock, which appears to be the result of ventricular tachycardia that persisted despite pacing. His initial EKG looks like this. And so we're going to jump into a couple of corrections based on some of the things that Chris just went over. So first question, his QT interval is 416 with a heart rate of 92. Ignoring for the moment that the QRS was a little wide on the EKG, what is the QTc calculated via Hodges formula? So the options are 472 milliseconds, 515 milliseconds, 508 milliseconds, 416 milliseconds, or 490 milliseconds. Okay, so we've got a few different answers, but I believe the correct answer is 472 milliseconds. And this is one where there is actually a correct answer. So as a quick good job, Paulina. As a quick review, so the Hodges formula is QT plus 1.75 times the heart rate minus 60. So if you play that out, you get 472 milliseconds in this case. And this is a case where the heart rate is significantly above 60 milliseconds. So you would expect that the Bazette formula would overcorrect that heart rate. So that's why we recommend using a linear formula like the Hodges. Now let's take a look at that QRS. So the QRS, according to the EKG, is 120 milliseconds. And the QT, again, is 416 milliseconds. Using the Bogosian method, what is the QTM? So how are you going to correct that widened QRS using Bogosian? Options here are 396 milliseconds, 316 milliseconds, 356 milliseconds, 296 milliseconds, and 416 milliseconds. And I would emphasize we're not doing the QTc yet, so we're not correcting for rate yet. We just want to know the corrected QT using the Bogosian method to correct for the widened QRS. Okay. So correct answer here is 356 milliseconds for the QT. Again, we haven't corrected for rate yet. And just a reminder of, we'll we'll take it one step further, and then I'll walk you through both steps. So after correcting for the widened QRS using Bogosian, so again, that gives us a QTM of 356 milliseconds. What is the QTc corrected for rate calculated via the Hodges? And again, the heart rate is 92 beats per minute. So this is similar to the first question where you've got a QT, you've got a heart rate, and you're going to use Hodges to correct for rate. So options here are 472 milliseconds, 356 milliseconds, 512 milliseconds, 490, or 412. Okay, 412 is correct. And I'm going to back up. So for the Bogosian correction, remember it was QTM equals QT minus half of the QRS, right? So the QRS was 120, half of that is 60. You subtract 60 from the QT and you get the QTM, or the Bogosian correction. And then when you're correcting that for rate, you get the Hodges formula again, and that gives you 412 milliseconds. So big question, maybe the most important question that we're thinking about as consultants, and this question does not have a right answer, though of course Poll Everywhere thinks it does. How would you categorize the patient's overall risk for Torsades? So think about all the things we talked about, right? He's got a cardiac history. We know his QT when we corrected using Hodges and Bogosian. We know that he came in because his AICD fired. We know he's got a history of alcohol use disorder, and he's got a history of major depression. So what do you think his overall risk is? Is it low? His actual QTc is only 412 milliseconds. Is it moderate? Despite a reassuring QTc, the patient still has that widened QRS. Is it high? Despite a reassuring QTc, the patient had a recent episode of VT with AICD firing. Is it low because the QTc is reassuring and the patient has a history of AFib, which is protective? Or is it moderate because while the QTc is reassuring, the patient has an extensive cardiac history, including implantable devices? Okay, so a few different answers. So this is a really important teaching point in my mind. So when my fellow, who's very good, got this case and on his own used Bogosian and Hodges to correct the QT, came to me and said, this is great. This guy is really low risk because his QTc is 412, and so we don't have to worry about any medications. And that's probably what I would have said as a fellow. But now I actually think about this very differently. And so I would agree that his risk is actually quite high. Even though his current QTc is within normal limits, this is somebody who just had an AICD firing because of an episode of ventricular tachycardia. And we know that those are arrhythmias that are highly recurrent. And so he's going to be somebody who's actually at a pretty high risk of having an arrhythmia going forward. And so I would think about him as high risk. The widened QRS piece is not necessarily an increased risk for arrhythmias. It may be related to the fact that he has a pacemaker and he has other factors, but you do want to think about that as an additional cardiac risk. And then the AFib, we sometimes do think of atrial fibrillation as protective because it's a fast heart rate, and usually people don't go into Torsades at fast heart rates. But again, I'm not necessarily thinking about that as a major mitigating factor. So this is a guy who I think is probably still at a high risk despite a pretty normal QTc. Okay. And we often get asked, how do you document this? How do you talk to teams about this? So this is just a snippet from my documentation in the chart about how I talked about his risk in my note. So although we can correct the QTc to under 500, accounting for the things that we know, his overall risk for Torsades is actually elevated given the fact that he recently had an episode of ventricular tachycardia and an AICD. And I was thinking about, okay, what's cardiology going to do? They're probably going to put him back on an antiarrhythmic since he just had a firing, and that may further increase his risk as well. And so for that reason, I thought it was really important that we kind of do a careful risk-benefit analysis of his psychiatric medications in terms of determining what he actually needed. So on that note, his psychiatric medications on admission include escitalopram, oxcarbazepine, hydroxyzine, trazodone, and quetiapine. With regards to QTc prolongation, which of these are you least concerned about? Okay, so a few different answers, but the correct answer here is oxcarbazepine. Of all the medications on this list, oxcarbazepine is actually the only one that has no signal for QTc prolongation. Escitalopram, we've talked about a little bit. It is one that I think about as pretty safe. It has a thorough QT study, which is kind of the gold standard, and it only shows a QT increase of about 4 to 8 milliseconds. That's pretty minimal. It's unlikely to be clinically significant, and escitalopram doesn't separate out from most SSRIs in most studies. And so I think about escitalopram as not that risky, but it definitely has a little bit of a signal. Hydroxyzine is one that we'll talk a little bit about, but hydroxyzine actually has some reports of QTc prolongation. Trazodone we're going to talk about a little bit more, and quetiapine is one that actually has an FDA warning related to QTc prolongation, though we'll talk a little bit about that specifically. All right, so let's talk about hydroxyzine. Which of the following is true with regards to hydroxyzine and QTc prolongation? So one of these statements is true. A thorough QT study demonstrated QTc prolongation of about 10 to 15 milliseconds with hydroxyzine. Hydroxyzine has never been associated with QTc prolongation. Hydroxyzine has been associated with QTc prolongation and mostly in the setting of overdose. Hydroxyzine causes greater QT prolongation than diphenhydramine, and hydroxyzine doesn't cause QTc prolongation, but is associated with Torsades. Which is the true statement there? So it turns out that hydroxyzine has been associated with QTc prolongation, but it's mostly in the setting of overdose. So there are some case reports of QTc prolongation, but again, they're mostly happening at toxic levels. So prolongation is unlikely with therapeutic doses. Compared to diphenhydramine, diphenhydramine actually causes more QTc prolongation or is associated with more cases of QTc prolongation. There's actually never been a thorough QT study of hydroxyzine, so that's a made-up one. But like many medications, especially many older medications, we don't have a thorough QT study. Other medications on admission that are non-psychiatric medications include atorvastatin, dofetilide, empagliflozin, and glucophage, as well as rivaroxaban. With regards to QTc prolongation, which of those medications would you be most concerned about? So this is kind of an important recognize the non-psychiatric medications that might convey risk question. And the answer here is dofetilide. So dofetilide is an antiarrhythmic, and it's one of the medications that is most associated with QTc prolongation. So that's one to recognize when your patients are on as carrying a significant risk. The others don't have much of an association with QTc prolongation. All right, so now we get into the hard part. 2 days following admission, this patient develops confusion, agitation, and hallucinations. The primary team asks which antipsychotic they can use that will carry the lowest risk of QTc prolongation. Is it IV chlorpromazine, IV haloperidol, IV olanzapine, PO quetiapine, or all of the above? All of the above carry equal risk. Where's the poll? Sorry. Okay. Lots of answers, but the correct one is that all of the above carry equal risk. And this is probably the single biggest point that I want all of you to take home from this talk today. All of those medications carry about equal risk for QTc prolongation. They cannot be separated out. We do not have head-to-head studies. We don't have thorough QT studies. The lore that IV haloperidol is so much worse compared to others is completely based on no evidence. We would group those medications together, and we're going to talk a little bit about that as well. But the answer in my mind is that all of the above carry equal risk. And so what I always tell my trainees is, if you are so concerned about QTc prolongation or Torsades that you don't feel safe using, for example, IV haloperidol, you should not feel safe using a different antipsychotic in that case, because we cannot separate those out. So let's talk a little bit about this. So antipsychotics and QTc prolongation. Typicals. As a group, the typicals lead to modest QT prolongation compared to placebo, and that effect is almost entirely driven by phenothiazines, specifically low potency phenothiazines, and probably thioridazine specifically. So even though chlorpromazine is a low potency phenothiazine, and I'll talk about this in a minute, we don't actually think that it separates out from other agents in terms of QTc prolongation. And that's been a little bit of a change in our thinking over the past year. With regards to haloperidol, oral and IM forms of haloperidol have consistently shown a modest QTc prolongation of about 5 to 8 milliseconds, which is actually less than most atypical antipsychotics. And in both, in some studies, neither form actually separates out from placebo. And in another study, IM haloperidol does not separate out from IM olanzapine. There is a little bit of evidence that IM and oral haloperidol might continue to cause a greater risk for ventricular arrhythmias, despite not causing more QTc prolongation, but the data there is pretty mixed and it's confounded a little bit as well. Again, with regards to chlorpromazine, the QTc prolonging effects are thought to be dose-dependent, which is true for most medications, but there's never been a thorough QT study. And even though it's often said that the IV form causes greater QTc prolongation than PO, there's, again, no evidence, no head-to-head studies. So our group in the past year has kind of reclassified chlorpromazine. We formerly listed it as high risk because it's a low-potency phenothiazine. But in reviewing the evidence, we think it's actually not really separated out from other agents. So back to the case, overnight, the patient is trying to remove his central line. You recommend IV haloperidol. Which of the following would be an accurate statement to document in the chart? Again, this is one where there might not be a single right answer. So you could say IV haloperidol causes more QTc prolongation than PO, but is less likely to cause EPS. Cumulative evidence suggests that patients receiving IV haloperidol should be placed on telemetry. While IV haloperidol has been associated with Torsades, the risk of unintentional self-harm due to agitation in this patient likely outweighs the risk of QTc prolongation, especially at doses less than 20 milligrams. IV haloperidol is associated with less QTc prolongation than IV olanzapine, or doses of IV haloperidol above 10 milligrams are associated with a greater risk for Torsades. Which of those is most accurate? Okay, so I would have documented choice C. So haloperidol has been associated with Torsades, but in this case where the person is about to rip out their central line, to me, that sounds like the risk of unintentional self-harm due to agitation outweighs that risk of QTc prolongation. And there's evidence that at doses less than 20 milligrams, the effect of IV haloperidol on QTc prolongation is minimal. Now, for those of you who suggested cumulative evidence suggests that the patient receiving IV haloperidol should be placed on telemetry, this is a technicality. The FDA warning suggests that patients receiving IV haloperidol should be placed on telemetry, but the cumulative amount of evidence that's come out since the FDA warning really doesn't support that. I have no belief that the FDA warning is going to change, but if we look at that critically, there's really not significant evidence to support that any patient on IV haloperidol should be on telemetry, and we'll talk about that as well. The other two, IV haloperidol is actually, there's no evidence that IV haloperidol causes more QTc prolongation than PO haloperidol. It is less likely to cause EPS. There's no evidence that IV haloperidol is associated with more or less QTc prolongation than IV olanzapine. And the final point, doses of IV haloperidol above 10 milligrams are associated with a greater risk of Torsades. We do think it's dose related, but actually the studies suggest that where you really start to see a separate effect is at doses of greater than 35 milligrams given over 6 hours. So let's talk about IV haloperidol. There's no thorough QT study. When we did our systematic review a couple of years ago, 10 of 11 prospective studies, which involved over 1,500 patients in doses of up to 20 milligrams, found no evidence of QT prolongation. IV haloperidol doesn't separate out from placebo in some studies. And there's no evidence that IV haloperidol causes greater QT prolongation than atypical agents or than oral haloperidol. The study that is quoted in that regard is a study on an inpatient psychiatry unit looking at different antipsychotics. It's a retrospective study, and they did not control for indication. And my assumption is that the patients who got IV haloperidol were older, sicker, and had a lot more risk factors than the patients who were receiving PO antipsychotics on that unit. There is, as I mentioned, this idea that doses above 35 milligrams in less than 6 hours may be associated with greater risk for Torsades. And one study suggests that most patients who developed Torsades had a QTc of greater than 550 milliseconds that was recorded prior to the episode. So based on our review, we revised recommendations for IV haloperidol, which are quite different from the FDA's recommendations. They include things like repleting electrolytes, using a linear correction formula, but we feel that for doses less than 5 milligrams daily, if the patient has less than 2 risk factors, you don't need any EKG monitoring. For patients who have 2 or more risk factors, or when you're using doses greater than 5 milligrams daily, we would recommend checking a baseline and a follow-up EKG. Daily EKGs we would consider for a total cumulative dose of greater than 25 milligrams, or in settings where patients have many risk factors that are changing rapidly, like in the ICU setting. And then you could consider continuous monitoring or telemetry if the QTc was above 500, or if the total dose of IV haloperidol exceeded 100 milligrams. If there's enough concern about QTc prolongation to stop using IV haloperidol, don't use a different antipsychotic. The following morning, the primary team reports that the patient is still agitated and asks about using droperidol. Which of the following statements is true about droperidol? Droperidol causes greater QTc prolongation than haloperidol. It's associated with less orthostatic hypotension than haloperidol. It's a low potency typical antipsychotic, so it's more likely to prolong the QTc. Most cases of Torsades with droperidol occur at doses greater than 50 milligrams, or droperidol can be safely used at much higher doses than IV haloperidol. Droperidol is enjoying a little bit of a resurgence, so this is a relevant one, whereas it wouldn't have been very relevant for the last 20 years or so. And so, yeah, the evidence suggests that most cases of Torsades that have been described with droperidol occur at doses greater than 50 milligrams. So it is a high dose effect. There's no evidence that it causes more or less QTc prolongation than haloperidol. Droperidol is actually associated with more orthostasis than haloperidol, and droperidol is a high potency butyrophenone, so it's not a low potency antipsychotic. Droperidol was actually in the 1999 APA guidelines was a treatment of choice for agitation along with IV haloperidol. And then in 2001, the FDA issued a black box warning because of QTc prolongation and Torsades, and it really stopped being used for about 2 decades. The emergency medicine folks have kind of brought it back into use, and so we're starting to see more droperidol being used. Importantly, the typical dose for agitation is about 5 to 10 milligrams. And one of the things that people like about droperidol is that the IM and the IV forms have a similarly fast action of onset, about 3 to 10 minutes, and a pretty good duration of action, 2 to 4 hours, sometimes up to 6 hours. Droperidol, again, the cases that were reviewed by some of the emergency medicine docs revealed that most of the concerning cases involved doses greater than 50 milligrams. They concluded that the risk of QTc prolongation and Torsades appears to be minimal with doses of up to 10 milligrams, though transient increases do occur in up to 9% of patients. And so the American Academy of Emergency Medicine has now advocated for using droperidol again, but only at doses up to 10 milligrams. And I want to point out that if the typical dose for agitation is 5 to 10 milligrams, and we were saying that droperidol is only safe up to 10 milligrams, that doesn't give us a lot of room to work with. So I'm not choosing droperidol a lot because I expect that a patient who receives a medication for agitation is likely to need to receive more medication for agitation, and we're going to pretty quickly hit a ceiling with droperidol, but you will see it being used in emergency medicine, and I don't have concerns about it being used at lower doses with regards to QTc prolongation. The primary team now tells you that they don't feel comfortable using IV haloperidol given the patient's multiple risk factors, and so they have started standing quetiapine. Which of the following is true with regards to quetiapine? Quetiapine carries no unique FDA warning regarding QTc prolongation. Quetiapine causes less QTc prolongation than olanzapine. Quetiapine has been associated with an increased risk for out-of-hospital cardiac arrest. Quetiapine achieves potent D2 blockade at low doses. I actually can't see the final option, but it's on your phones. Okay. So again, a few different answers. The one that I would say is most correct in this case is the third one. Quetiapine has been associated with an increased risk in some studies for out-of-hospital cardiac arrest. It does carry a unique FDA warning. There's no evidence that it causes less QTc prolongation than olanzapine. In fact, in a recent small study, it caused more QTc prolongation than olanzapine. Quetiapine does not achieve potent D2 blockade at low doses, which is one of the reasons that I tend not to use it in these scenarios. And it has, in case reports, been associated with Torsades. So when we think about other antipsychotics, just really focusing on what's new over the past year or two, again, this cardiac intensive care study showed a slightly higher risk of QT prolongation with quetiapine compared to olanzapine. There's also a 2021 cohort analysis of older adults who received quetiapine for delirium, which demonstrated a mean QTc increase of about 7 milliseconds, with 7% of them having a QTc greater than 500 milliseconds. So a few signals on quetiapine. Again, I don't think quetiapine is any worse than any other antipsychotics necessarily, but it's certainly not any better. A 2023 study with clozapine showed that blood levels predict risk for QTc prolongation. This really isn't surprising. Again, we think all medications have a dose-dependent effect on QTc prolongation. With clozapine, you do have to worry a little bit about whether it's heart rate confounded, right? Higher doses are going to be more likely to cause tachycardia because of the anticholinergic effects. And if they're using Bezet to correct, you're going to get higher QTCs. But I think that's probably valid nonetheless. And in 2022, we had our first case report of QTc prolongation with lorazepam, which previously carried no case reports. We still classify lorazepam as one of only 2 agents in the low risk category because there's really not significant evidence, but we do now have a case report. An important thing I want to highlight is that overall, I would not really suggest any correlation between the actual risk of an antipsychotic and whether or not it has an FDA warning. The FDA warnings are pretty haphazard in terms of this with regards to QTc prolongation. So this is how we risk stratify. Aripiprazole and lurasidone are the only two that really get a low risk category. Unfortunately, not super helpful in cases of agitation, though aripiprazole is sometimes used for hypoactive delirium. Everything else mostly groups together, with the exception of ziprasidone, iloperidone, and thioridazine, which are the ones that have more significant concern. Why don't... You were still good? Okay. All right. Primary team decides that the patient is probably withdrawing from alcohol despite normal vital signs. Which of the following statements about treatment for alcohol withdrawal and QTc is true? So of the various treatments that we might use for alcohol withdrawal, which of these is a true statement? Phenobarbital has greater risk for QTc prolongation than benzos. Clonidine has moderate risk in a thorough QT study. Valproate is most associated with QT prolongation among antipsychotics. Dexmedetomidine may increase the risk for torsade by inducing bradycardia, or IV lorazepam prolongs the QTc by 3.5 milliseconds on average. Only one of those is true. Dexmedetomidine does cause bradycardia, and that might increase the risk for torsade. So Chris kind of alluded to that. All of these other things are made-up statements. Phenobarbital carries no risk for QTc prolongation, nor do benzodiazepines. So there's zero risk with phenobarb or benzos. Clonidine has not had a thorough QT study, so we don't know what its risk is. And valproate does not cause any QT prolongation. So among antipsychotic or among anticonvulsants, valproate's actually one of the safer ones. The following day, the patient develops an unstable SVT and undergoes DC cardioversion. Which of the following medications that may be started in this setting would most likely prolong the QT interval? So this, again, is a good pattern recognition question, just know the medication to look for. The answer is amiodarone. Amiodarone is classically associated with significant QT prolongation. In fact, of all medications, it's one of the ones that most reliably prolongs the QTc. But interestingly, amiodarone is almost never associated with torsade. So it's a great example of this disconnect between QTc and torsade risk. We don't fully understand that, but it's an illustration that QTc is only a marker of risk for torsade, and even medications that have significantly prolongation of the QTc may not actually increase the risk for torsade. Okay, so I think we missed a slide, but the idea here is that the primary team, so the patient's getting towards discharge, and the primary team is saying, what are we going to do with their escitalopram? So they came in on escitalopram. We held it initially because we were thinking about them as high risk. Now they're closer to discharge. What are we going to do with the escitalopram? So what is your advice here? Do you favor restarting because the patient reports benefit and the absolute QTc prolongation with escitalopram is minimal? Do you favor holding all antidepressants because depression never required inpatient treatment and the patient is now on amiodarone, which you think makes the risk too high? Do you favor switching to citalopram because the patient reported benefit from escitalopram, so he's likely to derive benefit from citalopram, which is safer? Do you favor switching to sertraline because the patient has not previously tried sertraline, and sertraline is safer with regards to QTc prolongation? And I apologize that I can't see the final option, but it's on your phone. This is one that, again, probably has no right answer. All right, well, doesn't look, yeah, okay. So in this case, I would favor restarting the escitalopram. The patient has reported benefit in the past. And again, the absolute QTc prolongation with escitalopram is pretty minimal. It's unlikely to be clinically significant, even in somebody who has significant risk factors. I'd want to talk to cardiology about this, but you could make an argument that the benefits outweigh the risks. Of the other options, I wouldn't necessarily say he doesn't need an antidepressant just because he's never been inpatient, right? His depression is classified as moderate. We can figure out that it may have caused him significant distress. And so you may want to make an argument to start an antidepressant. Switching to citalopram, I'd say that's clearly the only wrong answer here. Citalopram is riskier than escitalopram and causes more QTc prolongation than escitalopram. So I would not switch him to citalopram if you're worried about the escitalopram. Switching to sertraline, that is totally reasonable. Sertraline, again, is what we think of as the safest antidepressant. And if he hasn't tried it previously, it could be a good option. And switching to mirtazapine, probably reasonable as well, though mirtazapine has a little bit more of a mixed signal. So overall magnitude of QTc increase with SSRIs is small. There's no indication for a baseline EKG with all antidepressant initiation. Citalopram is the worst offender, and it's definitely not my first choice for patients with pre-existing cardiac disease. And in cases where patients have a lot of risk, like if I had a compelling reason to start citalopram in this patient, that would be a case where I'd want to do a cardiology consultation, just kind of curbside cards and talk to them and get their sense of things. That being said, the most important thing that we can do as psychiatrists when we inherit patients is not reflexively take somebody off of the citalopram just because we're worried. You really want to do a careful risk-benefit analysis in that case. To talk about mirtazapine, because this is mirtazapine is actually the one that I get asked about the most often these days in terms of antidepressants. So there's no thorough QT study. There's a little bit of a signal for some QTc prolongation with mirtazapine. But what's now been done really nicely in 2019 is what's called a concentration QTc analysis, which is kind of an alternative to a thorough QT study that can utilize smaller sample sizes. And that found changes of 2.5 milliseconds at a dose of 45 milligrams and 4 milliseconds at a dose of 75 milligrams. So if this were a thorough QT study, we would say that risk is really minimal, and I wouldn't worry about mirtazapine. It's actually in line with the changes that were found with escitalopram. So it's not quite as good as a thorough QT study, but I think we can say overall that the risk with mirtazapine is pretty low. And there's also a 2020 study suggesting no change with mirtazapine in hospitalized patients. So I feel pretty safe using mirtazapine in patients with risk factors for QTc prolongation. It's still not my favorite medication in cardiac populations just because of the risk of weight gain and other metabolic effects. But from the purely QT standpoint, I think it's reasonable. The last question, and this is an important one and was a surprise for me. Patient's on the way out the door and he suddenly yells, "Hey, what about my trazodone?" The team pages you to ask for advice. You tell them, "Trazodone is too risky, prescribe a benzo instead. Trazodone is too risky, prescribe doxepin instead. Give him what he wants. Trazodone is too risky, don't prescribe anything." Or trazodone is too risky, prescribe melatonin instead. All right. So last year, I would have said, give him what he wants. This year, turns out we have some kind of concerning evidence about trazodone. So I don't love this answer, but I would probably have said in that moment, give him melatonin instead. If this wasn't coming as the patient was on the way out the door, I probably would have had some more options and tried to be more thoughtful. Maybe that's a case where you actually switch him to mirtazapine and drop the escitalopram or something like that. But I wouldn't give this guy a benzo because remember, way back, he's got a history of severe alcohol use disorder. I wouldn't give him doxepin because that's a tricyclic antidepressant, which carries some risk in him with his pre-existing cardiac disease. And I wouldn't not prescribe anything because it seems like the sleep is probably an issue for him. So of these options, melatonin is probably the best. But let's talk about this trazodone thing. So for a long time, there were just a few case reports showing an increased, showing some transient QTc prolongation in the setting of overdose. So I think at previous iterations of this talk, we've said trazodone's not really a big concern. Worry about it in cases of massive overdose, but at therapeutic doses, it's unlikely to prolong the QTc. And then it turns out that there is a thorough QT study that was done in 2020, and at doses of 60 milligrams of trazodone, which is usually kind of our starting dose, the QTc prolongation is 12.3. And at doses of 140, which isn't even where we get to our ceiling for trazodone for sleep, the QTc prolongation is 19.8. I just randomly found this as I was doing my literature search. There was no buzz on this. It got no coverage. The FDA issued no warning, which is kind of crazy, right? Because these numbers are actually greater than for citalopram. And so this is probably the biggest surprise to me this year. So I have changed the way I think about trazodone. I don't never prescribe it, but I certainly think about it as a drug that can carry significant risk in patients with QTc prolongation or risk factors. Now, again, the historical cutoff before citalopram happened was 20 milliseconds. So this doesn't quite get to the threshold, though you can imagine if they had tested 200 milligrams, it probably would have gotten above 20 milliseconds. And this actually puts it kind of in the range of ziprasidone in the ziprasidone thorough QT study. So it actually is very surprising. And I think we need to probably be a little bit more cautious about using trazodone in patients who are at risk. That being said, the literature does not have a lot of reports of QTc prolongation at therapeutic doses or Torsades at therapeutic doses. So there's a little bit of a disjoint between the thorough QT study and what we're seeing in the case report literature. But I'm a little more concerned about using trazodone these days. So this is what I wrote initially when they asked about restarting trazodone when he first came in. Because it has a more moderate risk, I'd be concerned. And because the patient was not at that time asking for his trazodone or saying he really needed it, the benefit did not appear to outweigh the risk. Margot, do you want to? Yeah, let's transition. All right. So a few other things in the slides, but I'm going to hand it off to Margot.
All right, I have nothing to disclose. So we're going to talk a little bit about kind of some special situations, and this is going to be in the context of a transplant patient. So this is Ms. C. She's a 25-year-old woman who identifies as a Black Puerto Rican with history of end-stage familial cardiomyopathy, status post a heart transplant. Her post-transplant course was complicated by volume overload and acute kidney injury requiring CVVH. She did not have return of adequate renal function, and so now she requires hemodialysis. So the first question for you is, what is true about QTc prolongation in heart transplant recipients? So the QTc is an unreliable marker of risk in the transplant population due to denervation of the sympathetic nervous system. High-risk antiarrhythmics like sotalol and dofetilide are contraindicated in heart transplant patients due to the high risk of Torsades. The QTc interval generally increases over time in the years post-transplant. A change of QTc greater than 60 in the first year after transplant is a predictor of increased long-term mortality risk. And then you can see the other one on your phone. Which was the last one. So the correct answer here is that the risk of sudden cardiac death is actually 4 times more likely in patients with QTc prolongation greater than 10% between when they first get the transplant and in the window between the first and second year after transplant. So this is something important to think about in the patients that you're seeing who have had a transplant, that year between 1 and 2, if you're seeing an increase of the QTc, that their risk for sudden cardiac death is going up during that time. So, there's actually not a ton of data about QTc prolongation in heart transplant patients. We do know that in general for the transplant population, there's a 4% annual mortality risk after that first transplant year. And there was a study by Vertovec back in 2006, which shows you that there's not a lot of literature on this, but they looked at 600 heart transplant recipients, looked at the QTc prolongation immediately after transplant, and then actually were able to follow patients for 17 years post-transplant. So what they found was that overall QTc shortens with time in a transplant patient. And so if you are actually seeing that QTc interval go up over time, that can be a marker of risk for sudden cardiac death and all-cause mortality. And this is another figure from their study. And so if you look at this first figure here, if they have QTc prolongation greater than 10% in that 1 to 2 year window, the hazard ratio for all-cause death is almost 7. It's almost 7 times more likely. And for sudden cardiac death, 4.5 more times likely. So this is something really to pay attention to in this population. So this patient, unfortunately, the week that she was scheduled for a planned kidney transplant from her sister, so this would be her second transplant, her 47-year-old father, who was also a heart transplant recipient, died unexpectedly from a cardiac arrest. And so she has had tremendous difficulty coping with his death since she too herself now has a heart transplant, and she's 25. And so she was referred to CU from the advanced heart failure team when she reported some passive thoughts of death to the team. And so in preparation to see her, you want to take a look at her most recent EKG just to get a sense of, okay, if I decided that I wanted to prescribe an SSRI, let's say, would we be able to do that? So thinking about what you might find on an EKG with a transplant patient, what would be unusual to find? So would it be unusual to find 2 sets of P waves, excessive atrial activity, right bundle branch block, asynchronous P waves with 2 different rates, bradycardia? And then the final answer on your phone. So unusual to find ventricular conduction from the recipient's native P wave. I show you this slide and this question really just to think about that there is a difference in what an EKG looks like when you have someone post-transplant. And I encourage you to go and look through how does a transplant actually work and what parts of the native heart are remaining. Usually there's still a portion of the atria remaining that are then connected to the donor heart. And so that will influence what you see on the EKG. So this is her most recent EKG that you pull up, and just looking at it right now, take a gander. It's it's a little bit hard to see, nothing necessarily jumping out. So I'm going to zoom in on, Chris talked about looking at leads V2, V3, or lead 2 when we're looking at the QT interval. So I'm going to zoom in on V2. And so the question here for you is, what do you think is the measured QT interval? So take a moment. I'm going to keep this up before we go to the answers so that you can get a sense. And if this one feels challenging, you're not alone. I think this one's hard to tell where the T wave ends. Yeah. Okay. So get a number in your mind. Okay. So do we think it's 310, 480, 240? And then the other answers you'll see on your phone, hopefully. All right, great, 360. Yeah, so that's what I got too. But I think, this one was really hard to tell, where does that T wave end? Does it end here? Does it end there? And so for her, I actually looked at a different section of her EKG just to confirm, okay, is this really 360? And when I did correct with Hodges, it's 414. So let's look at a different one. So this is from V4. And when I looked at this one, so if this is the beginning of our QRS complex, this is where I think the end of the T wave is. I think it's a little bit easier to tell, although you do have a little bit of noise there, but I would say it ends here. And got the exact same thing, QT of 360 milliseconds. So QTc Hodges is 414. So this was consistent. I felt comfortable that, this is what we were dealing with. And then I actually did go back and I looked at her EKG immediately post-transplant to see what that looked like, just to get a sense of, is her QTc getting shorter? Is it getting longer? And when we zoom in here, you'll see that actually her QT interval was 435. So it was longer after transplant. And then correcting with Hodges, we got a QTc of 467. So given what you know about this patient, would you feel comfortable starting sertraline if it turned out that she would benefit from an SSRI? So no, she has multiple concerning risk factors: heart transplant, family history of sudden cardiac death. She's on hemodialysis. Possibly her QTc is somewhat reassuring, even with the other risk factors. And then the last one is, yes, you'd absolutely feel comfortable prescribing. Yeah, okay. So I think this is also one of these where, the QTc is fairly reassuring to us, but this is a woman who, she is status post a heart transplant. She is on hemodialysis, which we know causes, pretty major and rapid fluid and electrolyte shifts with each session. And so, you can be at high risk of hypokalemia, hypomagnesemia, hypocalcemia in those cases. And her father, had a transplant and died from a cardiac arrest. So I think she does have some risk factors. I would probably say the answer is possibly, but I think you could go either way. But I think this is one where the EKG and the QTc is not going to give you the absolute correct answer. So just a note about hemodialysis. We know that actually sudden cardiac death is the leading cause of death in hemodialysis patients. Accounts for 34% of deaths. So it's a fairly big risk factor. And so it's common to see QTc prolongation in these patients. And, many of us, when we're writing notes about, optimization of risk or mitigation of risk, we talk about keep potassium above 4, keep magnesium above 2. And actually for folks who are getting hemodialysis, you want your potassium to be a little bit higher. And so shoot for about 5 or 5.1. You don't want to go much higher than that because now you're kind of in the risk for hyperkalemia, which you also want to avoid. But if you can keep the potassium a little bit higher, then when they come out of dialysis, they're not going to have such a low potassium level. So that I think is a pearl to take home. And then, there are contradicting studies about whether or not if you change the concentration of different ions in the dialysate that the patient is getting with the dialysis, that may help prevent some of these electrolyte disturbances. Data is mixed, and so I think it's just really important to work with your nephrology teams and talk to them when you have someone who's a high-risk patient and see what they have to offer. So kind of going back to our case, so Ms. C, she's scheduled to see you for your first appointment, and she initially doesn't appear. It's a virtual appointment. So about 10 minutes into it, you call her, and she picks up the phone and she says she forgot about the appointment, but she's able to step away, to a private location and talks to you. And she tells you that she was very hesitant to see you. She had to be really convinced by the heart palliative care team to see anyone in psychiatry. She feels uncomfortable with that idea of psychiatry. Said she saw a therapist once, stopped going after the first appointment because she just wasn't right for me. It wasn't good. And so you end up talking to her for an hour and feel like it goes well, and then decide with her that she's actually very interested in starting a medication and wants to come back. And so you set up follow-up for a week. And, you know, after the appointment, you realize that when she had talked about her father, when you were seeing her, that his name was familiar. And actually, you look back through your patient panel and found that he was referred to see you a few months prior to his own death. But when the scheduler had called, he had refused or declined an appointment. And so, you know, I just want to leave us with this thought, thinking about, you know, why might the father have hesitated to see psychiatry? Why might this patient have hesitated to see psychiatry? And just think about, you know, what social determinants may have been at play in those cases, and what could we have done, you know, better on our end. This is a real case and someone that I saw, and so, you know, then I wondered to myself, you know, should I have outreached this gentleman more, and thinking about people who may not, you know, have the best experiences with the healthcare system that, you know, really deserve that extra little push. And so, you know, I think in hindsight, I would have called him even after he declined. So I wanted just to leave that with us to think about. So leaderboard, Paulina is the winner. Where's Paulina? Fantastic. You were like the leader the whole way through. So congratulations. I feel like we need like golden calipers or something, some sort of prize to give out, but you get the award. So we are at time for today, and I want to be respectful of everyone's time, but happy to stay for any questions at all about any of the material. So we can stay in the room for a few minutes, but please, if you're going to go on to the next thing, don't hesitate to do so. And we'll be up front too. All right, thanks everybody.